Sairam everyone. Our speaker for this month's health webinar is Dr. Sathya Vani Ramasamy. Dr. Ramasamy was born and grew up in Mauritius. She did a bachelor's degree in medical sciences at the University of Mauritius before joining the University of Newcastle in the UK. She completed her specialty training in clinical oncology at the St. James Institute of Oncology in Leeds. Since 2015, Dr. Ramasamy has been a consultant in clinical oncology at Leeds training hospitals with a specialist area of interest in head, neck, and skin cancer. Dr. Ramasamy feels very fortunate to have been in the Sai organization at home in Mauritius for as long as she can remember, and currently attends the Sathya Sai Center of Leeds. Jai Sai Ram.
Jai Sai Ram. My name is Vani Ramasamy. I'm one of the clinical oncologists based at the Leeds Cancer Center, and I'm very grateful for having this opportunity to talk to you about oncology today. Cancer. The word cancer means different things to different people. It is often associated with fear and death. In some communities, cancer is still a taboo subject where people are worried what the perception of society will be towards them if they share their diagnosis. However, cancer treatment, diagnosis have changed significantly over time, and today I would like to talk about causes, prevention, diagnosis, treatment, and what support is available. And hopefully, by the end of the talk, we will be able to associate cancer with more words and maybe more positive words. So there are more than 200 types of cancer. The graph on the slides show the 24 commonest cancers in the UK, and you can see that the 4 top cancers are prostate, breast, lung, and colorectal. The incidence of cancer has been increasing and is still increasing. In 2016 to 2018, there was an average 375,000 cases each year. Incidence is higher in men, and also, as mentioned before, there is an overall increase in incidence rate. However, survival from cancer has also increased, and as you can see, there has been an improvement over the last 40 years, and cancer survival in the UK has doubled. So let's talk about what is cancer. So cancer is when abnormal cells in a specific part of the body grow and reproduce uncontrollably. So in the picture on here, you can see that these are normal cells and they look very similar to each other, and they are similar size and shape, and they are within boundaries. Whereas if you look at the cancer cells, they look very haphazard, and they are not within the boundary. As you can see here, they are starting to grow beyond the tissue. So the cancerous cells, they can divide and destroy surrounding healthy tissues, including organs, as shown in the picture, where you can see we call that tentacles like structures, and they invade the tissue and can also invade neighboring tissues and organs. Cancer sometimes starts in one part of the body before it spreads to other parts of the body, and this process is called metastases. 1 in 2 people in the UK will develop cancer in their lifetime. But what causes cancer? So this picture shows a cell, and our body is made up of trillions of those. So they are called the building blocks of the body. all those cells have a nucleus, and the nucleus is a bit like a control center. The nucleus contains genes which are made up of DNA, and DNA are proteins. The DNA carry information that makes you, for example, what color your eye will be or hair color, and you inherit DNA half from your dad and half from your mom. And that's why we can say that your eye looks same like your mom, or your hair is like your dad. But they also code for how the cell needs to behave. And by that, I mean they tell the cell when to grow, when to divide, and also when to die. So DNA, these proteins, can pick up mistakes, and these mistakes are called mutations. And mutation can occur on a daily basis as part of the natural life cycle of a cell, and sometimes external factors can cause those mistakes. An example of an external factor is, for example, nicotine, which is the chemicals found in cigarette. Most of the time, those cells can repair the mistakes. However, sometimes mutation is in an important gene, and those mutations can cause a cell to no longer follow instructions, and repair does not occur. And this process is what can lead to cancer. What I mean is that if there's a mistake in a gene that controls when the cell reproduce, and there's a mistake in that gene, so the cell doesn't know when to stop reproducing, so they just keep growing and reproducing, and that can lead up to cancer, also known as a growth. Therefore, developing cancer is partly chance and partly external environment. For example, I mentioned before, nicotine can cause those mistakes, that is mutations. So what are the risk factors of cancer? So these are the external factors that can contribute to the to cancer forming in the body. So these are the commonest one, but you will see there are much more than that if you look online. So the main one is smoking, alcohol, obesity, poor diet, lack of physical exercise, certain viruses, and the commonest one is the human papilloma virus and the Epstein-Barr virus, radiation, and that include X-rays, and even UV radiation from the sun, air pollution, increasing age, occupation, such as people who are exposed to asbestos have an increased risk of developing specific type of lung cancer, and also inherited faulty genes. So people can inherit faulty genes, hence have an increased risk of developing cancer in their lifetime. I just want to point out here that inherited faulty genes only make up 5% of all cancers, so they are very rare. However, most people will have a relative that has cancer. It doesn't mean that they have inherited faulty genes. It's just cancer is very common. As mentioned, 1 in 2 people will get cancer. It increases with age, so everybody at some point will know or will have a relative that is affected by it. So just coming on to prevention. So what can we do to prevent the development of cancer? So if we think about those risk factors, things that we can do will be, for example, leading a healthy, active life. So a healthy diet and regular physical exercise. Stopping smoking, that's one of the biggest factors that have caused a decrease in cancer. And just to mention that if anybody is interested in stopping smoking, there is help available on the NHS. And to try avoid excess alcohol and sun protection, that include a cream with good SPF and star rating, and also just general advice such as staying in the shade or wearing a sun hat when there is excessive sun. As mentioned before, some viruses can are risk factors for cancer. So vaccination can prevent cancer, and that's vaccination against the human papillomavirus. So the HPV vaccine protects against high-risk HPV. What I mean by that is that HPV has different strands, and the vaccine protects against the ones that are high risk of causing cancer. This protects against cervical cancer, mouth and throat cancer, and some cancers of the anal and genital areas. In the UK, this vaccine is available to all children aged between 12 and 13, and they get 2 doses of the vaccine. Just to mention here that it used to be available only to girls, but nowadays it's available to both girls and boys. In 2021, a UK study actually found that cervical cancer rates were reduced in the 20s in England who were offered the vaccine aged 12 to 13, and that is a significant decrease in the rate of cervical cancer. The other part of prevention is also screening. So screening is a test that looks for cancer in healthy individuals, that is even before you develop symptoms or you feel anything. So it helps spot cancer at an early stage, and by spotting cancer at an early stage, there's more chance of successful treatment, and therefore screening saves lives. We are very lucky in the NHS, we have 3 national screening programs. I will just quickly run through it. And for all 3 of them, if you're registered with your GP, you should get invite automatically. So we have the bowel cancer screening for people aged between 60 and 74 years in England. Those age differ if you're in Wales or Scotland. And this is done every 2 years at home. So you get a fit kit delivered by post to your home, and you do the test and then you send it back. Next, we have the breast screening. So this is available for all women aged 50 to 70, and the age is increasing with time. And this is a mammogram that needs to be done. And a mammogram is basically an X-ray of the breasts, and this is done every 5 years. The NHS is increasing the age of screening, which is going to be from 47 to 73. But if you want to be screened even after 73, you can let the screening services know and you will be called. And I just wanted to mention as well, like there's a lot of campaigning for everybody to be breast aware. So it is recommended that at least once a month, all women examine their breasts. So it's the Dutch Look and Check campaign. So look for any changes, such as lump, change in size or shape, skin changes or discharge, and feel the breast to see if there's any abnormality that you can feel. And if there's anything that worries you, is to check with your GP. And the third screening is the cervical cancer screening. This is offered to all female aged between 25 to 64 every 3 to 5 years. And in this test, which you have to go to the GP for, is a sample of cells are taken from the cervix. We mentioned about the HPV vaccine. Even if you had the vaccine, the screening is still recommended, as HPV vaccine doesn't protect against all strands of the virus. So diagnosis. There is loads of signs and symptoms that are suggestive of cancer. And they can be anywhere in the body. I'm not going to go through all the signs and symptoms, but I'm just going to summarize that if there is anything that you're worried about, any signs or any symptoms, the most important thing to do is to contact your GP. And if there's a chance that those symptoms might be associated with cancer from your history and examination, then you will be referred to the appropriate specialty in the hospital by the GP. And this usually happens within 2 weeks under the 2 weeks waiting rule, which is basically if cancer is suspected, then the specialty in the hospital should see the patient within 2 weeks. Then patients are seen by the hospital specialist and tests are arranged. If any of the test results confirm cancer, patients are then discussed in a multidisciplinary team meeting in the hospital and then referred to the oncology team. So oncology is a vast specialty and it is made up of mainly surgical oncology, clinical oncology, and medical oncology. So surgical oncology is made up of surgeons that do cancer operations. Clinical oncologists, they offer radiotherapy and chemotherapy, and medical oncologists are specialists in chemotherapy. So just to talk about a multidisciplinary team meeting, which are very important, and every single cancer case in the UK should be discussed in a multidisciplinary team. So the multidisciplinary team is made up of many specialties, allied health professionals, as shown in the picture on the slide. And what happens at the MDT is that each patient's case is presented and the results discussed, and then a plan is made for the management or the treatment of the patient. So, treatment decision is not made by one person, it's made up by team. And at the end of the day, it's the patient that is the boss. So the patient is given the choice and decide on the treatment that they want to go forward with. So once the patient is referred to the oncology team, further tests might be needed. And that is to help stage the cancer. Sometimes we need to check for presence of specific markers on cancer cells, which would guide us to what treatment would be best suited for that patient. And also to check how well the organs of the patient is working, for example, the kidney or the liver, because the treatment that we give can be toxic and we need to make sure that patients are in good health and can handle the treatment before we go ahead with it. So common tests that are used are biopsies, which is basically taking a sample of the cancer and looking under the microscope. So we can look at the cells and look for specific markers that are on the cancer cells that we can target with medication, a blood test, ultrasound scan, a CT scan, MRI scan, PET-CT scan, and bone scan. And also, I just wanted to mention that not every cancer patient need all these tests, because sometimes we get patients that ask us that I've had a CT scan, why don't I need an MRI, and vice versa. So scans are pictures and they help us see the tumor, and different areas in the body are seen differently in different picture. So just to illustrate that, this is a CT scan, and just to orientate your everybody, so this is the jaw of somebody and this is their neck, so they are lying on their back, and there's a cancer in the tonsil, which you can see here. So this is a CT scan. This is an MRI scan where you can see that the tumor is much better defined. So you can see the borders better compared to the CT scan. And this is a PET scan where the tumor actually is in red. So, there are differences in scan, and different areas of the body are viewed better by one type or another type of scan. So coming on to cancer staging. So staging is a way of describing the size of the cancer and whether it has spread beyond where it has started or not. And cancer staging is important because first it helps us decide on treatment. It also gives doctors a common language. So if I say somebody has stage 2 lung cancer to another oncologist elsewhere in the country, they know which stage the cancer is and can relate to, or discuss the patient management better. It also allows us to compare treatment results with studies, and it can help with prognosis. There are two main types of staging, just to mention. So there's what we call the TNM staging, which the T represents the tumor size and whether it's invaded any organs around it. N is for node, which is the first place, if you want, that the cancer usually spread to, and M is for metastases, whether it's spread to other organs. And then we have the number staging, where we stage cancer as 1, 2, 3, and 4. And also I wanted to emphasize that staging is different for each type of cancer. For example, in somebody with tonsillar cancer who has stage 4 cancer can still be offered treatment to cure the cancer, whereas some other type of cancer, for example, lung cancer, may be stage 4. In stage 4, there is no curable treatment available. So we'll now come to types of treatment. So the main treatment for cancer is surgery, chemotherapy, and radiotherapy. I'm not going to talk about surgery, but I'm going to go briefly over chemotherapy and radiotherapy. So chemotherapy, or what we call nowadays systemic therapy, is a group of drugs that we give that goes everywhere in the body. So it travels around and can target cancer cells everywhere in the body. So what makes up systemic treatment is chemotherapy, hormonal treatment, targeted therapies, and immunotherapy. And radiotherapy is basically extra treatment and is localized to one part of the body. And we have two main types of radiotherapy. One is called external beam radiotherapy and the other one brachytherapy. Just before I describe the treatment, I just wanted to go through treatment aim because I think sometimes those words are used and they might confuse patients, or patients are not 100% sure what they actually mean. So we have treatment that aim to cure cancer. We call that curative or radical treatment. And as the name says it, the aim is to get rid of the cancer. Then other aim of treatment is neoadjuvant treatment. And neoadjuvant means that we are giving this treatment before the main treatment that would get rid of the cancer. And the aim of this treatment is to shrink the tumor in the hope of making the curative treatment more effective. Just to give an example, some people might have chemotherapy before they have surgery for breast cancer. So the aim of this chemotherapy is to shrink down the cancer so that the surgery is more effective or more successful. Then we have adjuvant treatment, which is basically additional treatment after the main treatment. And adjuvant treatment is usually given to lower the risk of cancer coming back. For example, you can patients can have a lump removed from their breast and that has taken the cancer away, but they are offered radiotherapy as an adjuvant treatment to decrease the risk of them getting cancer in that area in the future. Then we have what we call palliative treatment. So palliative treatment, the aim is not to cure or get rid of the cancer, but is to relieve symptoms, improve quality of life, and help people live longer and more comfortably. So these are the four aims of treatment. And just going through treatment, so I'm just going to talk about chemotherapy first. So chemotherapy works by killing cancer cells, which are fast-growing cells, and they travel around the body. However, chemotherapy doesn't recognize cancer cells, so they kill all fast-growing cells. Hence, you get quite significant side effects from that. It can be given through a vein, and some people can have what we call lines or access to give the treatment. Some might have a line in their arm, or some of them have it on the chest called the Hickman line. But chemotherapies can also be given as a tablet form. Some chemotherapy are available as tablet. Chemotherapy is given in cycles, so you will hear that people are having 6 cycles, and a cycle is basically you get your treatment on day 1, and then you have a 3 weeks break where you recover from the treatment before you get your next lot of treatment. You can have one drug at one time, or you can have a combination of drug at one time. And chemotherapy can be used as an adjuvant treatment, neoadjuvant treatment, or palliative treatment. And it can also be given on its own, or it can be given together with radiotherapy or hormone treatment or targeted therapy or immunotherapy. So chemotherapy side effects, I think a lot of people are aware of those side effects, and a lot of time, as soon as you mention chemotherapy, patients ask you whether I'm going to lose my hair. So each chemotherapy is different and has different spectrum of side effects, and the most common ones are shown in the picture. But just to mention that no 2 individuals are the same, and no 2 individuals having the same chemotherapy will have the same side effects. And side effects varies from very mild to very severe. With each chemotherapy cycle, we give a lot of supportive medication to help with side effects such as anti-sickness, steroids, etc. So this is in a nutshell about chemotherapy. Targeted therapy. So targeted therapy work by targeting specific areas on the cancer cells. So if you look on the picture here, it shows that the pink triangle are the specific targets that the drugs are working on, and therefore they will lock those cells, and hopefully the cancer cells will die. There are different types of targeted therapies, and immunotherapy is one of them. And it can either be given by vein or as a tablet. It is more specific than chemotherapy because, as mentioned before, chemotherapy doesn't recognize a cancer cell. It just acts on all fast-growing cells, whereas targeted therapy, they recognize the cancer cells by those markers on the cancer cell surface. It can be given either in the adjuvant setting or the palliative setting. And the common side effects are different from chemotherapy, actually, and they are skin changes, diarrhea, fatigue, flu-like symptoms, but they have many more side effects, but each one have its own side effects, so I can't go through the whole list. So the next type of treatment is immunotherapy. Immunotherapy was introduced maybe in the last 10 to 20 years, and success from immunotherapy has been very good over the last few years, and they are used more and more in the clinic. And what immunotherapy does, it uses our own immune system to fight the cancer. They do that by helping our immune system recognize and attack the cancer cells. Tests sometimes are needed before you have immunotherapy, and this is to check whether we feel immunotherapy is likely to work for a patient. And again, it can be given through a vein or a tablet, and they have different side effects because of the different mechanism that they work, and the commonest one are shown in the picture, and they mainly cause inflammation of organs. So coming on to radiotherapy. So radiotherapy is basically X-ray treatment, and it focuses on the area of concern. So it's localized treatment. It's basically hitting a target every single time. It works by damaging the DNA, which are the proteins that tell the cell what to do. And by so doing, it causes cancer cells to die. And radiotherapy can be used to cure cancer, to palliate cancer, but also adjuvantly or neoadjuvantly. The number of radiotherapy treatment varies from patient to patient, and that depends on the type of cancer they have, the intent of the radiotherapy we're giving. So there's lots of factors, but usually radiotherapy is given on consecutive days. So you can hear people having 3 weeks of radiotherapy where they come every day, Monday to Friday, but usually not weekends. And radiotherapy takes only about 15 minutes. And it's really just like having an X-ray where you lie down and the machine turns around you, but you can't see or feel anything at all. So radiotherapy, again, can be given on its own or with chemotherapy and immunotherapy. And the side effects of radiotherapy depend on where the treatment is being focused at and what is the dose. So obviously the higher the dose that we give, the more side effects the treatment will cause. So radiotherapy has changed significantly in the past few decades. So I wanted to take a few minutes to talk about this, because a lot of time we have patients who come, and when radiotherapy are offered, they tell us how their grandparents had radiotherapy and how horrible it was, or what experiences they have. But this has changed significantly over time. It's a bit like how the mobile phone has changed. So just to illustrate what I mean, so radiotherapy, as mentioned before, is like having an X-ray done, and it's focused on one area. And an X-ray usually is a square or a rectangle. So you can't get a shape X-ray. By that I mean, for example, if you take a picture with your phone or a camera, you get a square. If you can see, there's a mat in the picture here, or part of the door. Unfortunately, you can't only get the door, you will get the background as well, so the square that you treat. So in a very similar way, cancer cells, unfortunately, are not all square or or rectangle. They are different shape, and they can be next to an organ. But previously radiotherapy, you could only treat square. So if we put a square to get all the cancer within it, you can see that the heart will be treated. The heart also will have the radiotherapy dose as it's within this square, and we can't just treat the green. The whole of the yellow will be treated, hence more side effects. However, with advanced technology, this has changed significantly. For example, nowadays with an app, you can take out all the background and you can get a nice picture of only the dog and not the mat or part of the door. In a similar way, nowadays the radiotherapy beam, or rays if you want, can be shaped around the cancer. And if this is the green blob is our cancer that is close to a sensitive organ, then we can shape. This is the X-ray shielding leaf, and we can shape the cancer much better. And in so doing, we are treating much less normal tissue around. And this, you can see in this picture. So this is the square of an X-ray, but there are many tiny lead shielding leaves that can come in and out and shape the cancer. And what this allows us to do is to avoid healthy tissues around, and this translate to decreasing the side effects of treatment. But if we can avoid the healthy organs, then we can increase the dose as only mostly the cancer is getting that, and therefore increase the success of treatment. So this is in a nutshell treatment of cancer, treatment with radiotherapy. And you can, and these new techniques, you can sometimes hear them being mentioned, and they are abbreviated IMRT, VMAT, SBRT, or IGRT. And brachytherapy, which is another type of radiotherapy, is what we call internal radiotherapy. And within brachytherapy, a small radioactive material is either placed inside or very close to the cancer. And this allows us to deliver very high dose to the cancer and not to a lot of normal tissue around. Common cancers where brachytherapy is used is prostate cancer, cervical cancer, vaginal cancer, and uterine cancer. So how do we decide which treatment to offer a patient? So this depends on a lot of factors, and those factors are, for example, which type of cancer the patient has, which cancer, what type of cancer, but that means whether there are any specific molecules that we know about, what stage of cancer, how fit is the patient, because all these treatments come with side effects, and we need to be sure that the patients are strong enough to tolerate the side effects. Whether they have other health problems, because that can impact on what treatment we use or not. Other medication, because some medication can interact with cancer treatment. The age of the patient, saying that we don't not offer treatment beyond a certain age. It's just there are some treatment that we know with advanced age can be tolerated less well. And also the ability to come for treatment. For example, with the aging, as cancer increases with age, for example, in my practice, I have a lot of patients who are above 80 that needs to come for daily radiotherapy, but because of other medical problems, physically they can't come. So then you need to tailor the treatment and accommodate what they are able to actually do. And also it's the patient choice. So taking all this into account, you can see that each treatment is personalized for that patient. So this brings us to the end of treatment. And what I wanted to talk next is support. So there's a lot of support available for patients and their families who are dealing with cancer. And being diagnosed with cancer is life-changing, and this is regardless whether the treatment is to cure the cancer or is to palliate the cancer. And as mentioned, it's available for the patient, but also for the carers that are looking after the patient, because this is a big and difficult task. It's available throughout a patient's journey and beyond. By that, I mean, even if somebody has finished their treatment and have been clear of cancer for 5 years and being discharged, they still sometimes have to cope with the long-term side effects of treatment, and there is support available for that, and the family again. Different type of support is available, both in the hospital and the community, and these include physical support, for example, if there's any physical disability as a result of the cancer, emotional support, psychological, financial, because that can be very important, and also that can be a burden to a patient having cancer treatment, and spiritual support. The key thing is that because everybody has different needs, sometimes the healthcare providers don't know what you need unless you ask. So one key message, if you want, I wanted to pass on is support is available, but please don't hesitate to ask for it. So from the hospital team, you will have support from all the staff that are involved in the patient, in looking after the patient and the patient pathway. So that includes the staff on the ward, the radiotherapy staff, the nurses, the volunteers, the social workers, the physiotherapists, and all the other therapists, as well as the chaplaincy and the admin staff. So this slide gives you an idea of who is available for support. And again, you need to please ask what support you need, because sometimes people don't know unless you tell them. And in the community, you have also quite a lot of support available from GPs, palliative team, pharmacists, district nurses, and all the health allied healthcare professionals in the community. And I'm still going to stress on ask if you need support. And then everybody has their own support network. So you can have family, friends, and neighbors. I just wanted to say here that sometimes we have relatives or friends that are affected by cancer, and we want to support them, but sometimes we don't know what's the best way to do that. So it's very important to kind of let them know that you're there for them. But of course, if your friend or your family is affected by cancer, it will have some effect on you as well. So it's first to check in with how you're feeling and deal with that, but then offer support. So there are sometimes we don't know how to help, but there are different ways that we can help, and just examples of what can or can be helpful. Again, everybody's different, so what is helpful to one person will not be to the other. And also I think it's quite important to ask for permission, for example, before visiting or before giving advice or asking a lot of questions, because everybody's different. And sometimes patients are bombarded by advice from everybody, and then they are confused about what is the right thing to do or not. So things that I can think about that are helpful sometimes are, for example, offering to do chores, because they can be really tired from the cancer itself or the treatment. For example, doing the groceries, cooking a meal can be really helpful, babysitting kids so that they have a little bit of time to rest, and driving people to their appointments. That can be really helpful. I mentioned some radiotherapy treatment can be every day for 6 weeks, and that's a toll on the patient and their family. So if anybody is free to help, even getting them to the hospital once or twice a week can be life-saving. Or you can go for a walk, and it's also to kind of treat them the same, which sometimes can be difficult, and talk about other topics other than their health or the treatment that they are going through. This is just some ideas that I thought about, because I'm just thinking about myself. Sometimes you want to be helpful, but you don't know how to be helpful. Other support available is support groups. So they can be local support groups or national support groups, and a lot of hospitals, they have support groups for each type of cancer. For example, the head and neck cancer group or the colorectal support group. And again, please ask. You have charities such as the Maggie's, the Macmillan, and hospices, and sometimes the support that you get from them is immense. We have lots of positive feedback from patients. And also you have faith groups, that can be really helpful, and a lot of online resources. To be honest, there is so much online resources that it should be used with caution. Those are some of the commonest and very useful resource that I have listed there. And you just need to be careful, because sometimes you don't know where the information is coming from and whether they are genuine or not. So just be careful with the online resources. And again, I just want to stress about ask for the support that you want or you need. So just to conclude, there has been a significant improvement in the diagnosis and treatment of cancer. Nowadays, the World Health Organization classifies cancer as a chronic illness, as more people are living with cancer rather than dying from cancer. And maybe as a society or as part of the society, we need to empower those patients to live as normal life as can be. Screening can save lives. We are very lucky that screening is available in this country and it's free. So please, when you're invited, attend. And there's lots of support available around, from friends, family, from the hospital team, and also from the community team. And please don't hesitate to ask. The worst that can happen if you ask is that you are told no, there's no support, but the best that could happen is that you can get what you needed or wanted. So thank you everybody for your attention. Hoping you're still awake. But I will also like to thank my husband, who's given me the time to do this, to support ideas and also proofread my presentation. And I don't often do it, but I would like to take this opportunity to thank my family for their support throughout my studies and my career. And they've always been behind me, whatever I chose to do. I would like to extend my deepest thanks to the SAI organization, including the Health Committee, Sister Gayatri, Dr. Sheetal, Dr. Upadhyay, the media team as well, that has helped me with this. And last but not least, I would like to thank Swami for having given me this opportunity to share this talk with you today. Thank you very much.
Om Sai Ram. Thank you, Dr. Ramasamy, for a very informative presentation. You have really explained about the various types of cancers, how to prevent cancer, what happens after a cancer diagnosis. Many of us have heard about oncology, but really you filled in the blanks for us. The various treatments, and of course, all the support that is available. So a striking point you raised is that 1 in 2 people will have cancer in their lifetime. So it is something that we all have to know about. So we have a few questions that have been posed. So the cancer survival figures have doubled in the last 40 years, which is excellent news. So what advice would you like to give cancer survivors to maximize their chances of keeping in cancer remission?
Thank you for that. So what can be done? So what I thought about is that first, patients get follow-up appointments and sometimes follow-up scans. So it's very important that you do attend for the follow-ups and for the checks as well, because, if there's anything, then those appointments and checks will help us diagnose early or, guide you to the right place. Also, to kind of minimize your risk factors. So for example, if somebody was smoking and then they've gone to cancer treatment, then we highly recommend that they stop, because we do know that risk factors can increase your risk of getting cancer. And also, you continue to lead a very healthy and active life. And you shouldn't be scared to reach out to your team if you're worried about anything, whether it's a small thing or a big thing. We always say we rather you ask if you're sitting at home worrying whether this is something I need to check or not. And also to try be positive and be content, and also share the successes, because as you say, many people will be diagnosed with cancer, and a lot of time we only hear the stories of people that hasn't gone well, but there are many stories that people have done very well with their treatment. So maybe share those as well, so people have the encouragement if they have been diagnosed and need to go through the treatment.
That's brilliant. Thank you. Absolutely. It's like being given a second lease of life. So thank you for that. I know that as a GP, it may not be always easy to get an appointment with us, but we are always happy to see people, to investigate, to refer as well for any diagnosis of cancer. So yeah, I would like to reassure people that, please do come and see the GPs. So talking a bit, looking at other questions about, you explained about a PET scan and a bone scan. Can you give us a bit more information of those different types of scans?
So a PET CT scan, so a PET scan is usually done like the PET part of the scan is done, but also a CT scan. So difference between a normal CT scan, if you want, the PET CT scan, a tracer, radioactive tracer is injected in the bloodstream. And it's a scan that looks at the function of cells. So usually a tracer that we commonly use, it detects glucose in the body. So, highly active cells will basically light on the scan. For example, if you do a scan for anybody, the brain will light up, the heart will light up. That's just because those organs are constantly working. So cancer cells are very active, as we mentioned, so they tend to pick up, the tracer tend to pick them up as well, so they light up on the scan. So this is a PET CT scan, and a bone scan is similar. So you again have a tracer injected in you, and this detects the abnormality or the areas where the bone doesn't function normally. But I just wanted to say that, if something is positive on a PET CT scan or a bone scan, it doesn't necessarily mean that it is cancer. You have other, like, for example, in a bone scan, arthritis will cause abnormality on the bone scan, or injuries, or for a PET CT scan, even infection or inflammation will show something. So it is not specific just for cancer. So, an abnormal scan doesn't necessarily sometimes mean that it is cancer.
Oh, thank you very much. That's really good to know all the detail around that. So abnormal things may not always be cancer. So our next question is about, if patients are about to start chemo or radiotherapy, you've got the families and carers, they want to help them to minimize the side effects, to support their physical and mental well-being. You touched on some of the helpful hints and tips. Can you just remind us again, tell us a bit more how we can help these families or patients?
Yeah, so for the patient itself, just thinking about, what we see in the hospital, I think first is to ask if, things hasn't been explained clearly. Sometimes as an oncologist, you think that the patient has understood, or you think that you've explained it well, but actually you might not have. So, it's just to ask, because I think that if you understand the treatment, then you tolerate it better, but also you are aware, so you know what to expect. So, read the side effects profile, so you're not scared if something happened, something that is expected. And as mentioned, with treatment, sometimes we give a lot of supportive medication. And if you're not sure how to take it or when to take it, to ask. because so many times we have patients that come for the next treatment and then they have been unwell, but they haven't taken the medication because they didn't know how or if they could take it. And other things I can think about for the patient is that if you are having side effects, don't be scared to phone. We have 24/7 numbers that we give. So again, if you are at home thinking, should I phone for this? Then just phone, because it might be a very simple thing that, you know, over the phone, whoever's answering at the hospital will just tell you, oh, it's normal, don't worry about it. But it can also be something that you need to come to hospital, and the earlier we can deal with side effects, the better. And I think some patients are scared that if they tell us they have side effects, we're going to stop the treatment. But, you know, there are means and ways that there are other things that we will do before we stop the treatment. So it's to ask. And for the carers, it's to basically, you know, listen to the patient, what their needs are. Don't give too much advice until you're asked, because, you know, they get bombarded with a lot of things. And also for the carers themselves is to look after themselves, because it's very difficult to look after somebody else, especially when you feel quite helpless and you don't know how to help. And there are help for them as well. All the support groups is for the family and for the patients. So don't hesitate to ask for support as well and look after their health as well.
Oh, that's really important. Yes. So the whole family, you know, we want them to get through this treatment in the best way possible. So thank you very much. So another of our questions was about specifically like the different types of radiotherapy. You mentioned about brachytherapy. Can you know, explain what that involves? And, you know, if an implant's placed inside the body, does it have to be removed? So
so there are other cancers that we use brachytherapy for. Example, even skin we use brachytherapy, but the commonest one is for prostate and cervical cancer. So for prostate cancer, implants are actually put inside the prostate, and these are actually invasive procedures. It's done under general anesthetic. And for the prostate cancer, the one that are called radioactive seeds, if the seeds are placed inside the prostate, then this is not removed, it's placed, and then after that, the patient goes and the radiotherapy works in the background. And the difference is that brachytherapy, if you're very close to the cancer, you can deliver a very high dose. And if you can actually put the seed in the tumor, then, you know, you're treating you're treating to a very high dose, whereas the other radiotherapy, which is like an X-ray, it has to go through your skin and other organ to reach the cancer. But for cervical cancer, there are what we call applicators that are placed near the cervix, and this is also done on the spinal. And for this one, usually what happens, you get it done, and then you go to the ward. And then afterwards, when all the treatment is checked, you go down and, you know, machine is attached to the applicators, you get treated, and then you get the applicators removed before you go home. So if you want, these are the two main cancers that we use the brachytherapy for.
Thank you very much, Dr. Ramasamy. You have cleared several doubts that some of our listeners have had. I would like to thank you again for all your hard work for the presentation, so that all of us could, you know, understand a bit more about this journey and, you know, how to support ourselves and our families and others. So I would like to say thanks to our beloved Swami for giving us all the opportunity to undertake this seva today. Our thanks also to the wonderful media team for all the behind-scenes help to make this possible, and also to the National Healthcare Committee for putting these presentations on so that all of us can benefit. Our next webinar is going to be on Tuesday, the 2nd of August. So please join us for another interesting session. But from all of us, thank you. Jai Sai Ram.
Thank you. Jai Sai Ram.